Alright, so this is a recap video concerning heart failure. So heart failure is basically you're not being able to effectively pump. Your heart isn't able to effectively pump, which causes a starvation of oxygen and blood to needed tissues and organs. This is a blood flow video that's pretty good, I think. So if you have a question and want to watch a blood flow video, there you go. So it occurs when the heart is not able to perform its task of pumping blood efficiently throughout the body, which results in an inability to meet the demands for O2 and nutrients. And it's also indicative of heart disease when there is a problem with the contraction of the heart or the filling of the heart. So contraction is more systolic dysfunction, and filling is more diastolic dysfunction. There's some stats for you. So systolic heart failure is characterized by a weakened heart muscle, whereas diastolic is characterized by stiff and non-compliant heart muscles. So your ejection fraction, which is the amount of blood that's ejected with each contraction, is only going to go down with systolic heart failure, because in systolic heart failure, your heart is actually weaker. Whereas with diastolic, it's more that your heart is stiff and it's not compliant. You're going to have left ventricular hypertrophy, like I said in class, with diastolic heart failure, because of the fact that your heart is so stiff and non-compliant that ventricular muscle builds up and causes less room to be able to squeeze out the blood. So your EF is normal in diastolic but reduced in systolic. There's your classes. That's basically, it's based on your symptoms of heart failure, and it's also based on your natriuretic peptide. There's a video that's not working. Khan Academy is where I got the videos. I highly suggest watching them if you're confused. Preload and afterload. So preload is the volume that enters the ventricles, and afterload is the resistance that is in your left ventricle that your blood has to overcome. So health promotion, disease prevention. So if you are trying to prevent the disease or promote, you want routine exercise, a low sodium diet, smoking cessation. But if you have the disease and you're trying to not get in an acute state, then you might want to tell the patient to restrict their fluids, to adhere to their medicines, and to have routine visits to their primary care provider. Heart failure causes, so we have the word failure to help us with the mnemonic. So fatty heart valves, arrhythmias, infarction, such as a heart attack, lineage, uncontrolled hypertension, recreational drug use, and then evaders, which is like your bacteria, viruses, and then ETOH. There's major and minor risk factors, which the failure pretty much covers a lot of that. You have right-sided and left-sided heart failure. Right-sided is going to be dealing with the periphery, the peripheral systemic circulation, and left-sided is going to be dealing with pulmonary. So right-sided, you're going to have congestion in your peripheral tissues and your viscera from right ventricle failure, but you're not going to have right ventricular hypertrophy. The failure of this right ventricle causes an inability of the heart to accommodate for venous blood return. So you have JVD, which can occur from an increase in venous pressure. So you have all this fluid basically going around in your body, so you have an increased JVD. It also increases your hydrostatic pressure, which means that you have excessive fluid circulating in your body, because if you remember back in fluid and electrolytes, we talked about how hydrostatic pressure, if your hydrostatic pressure is higher, your fluid is going to come out of your capillaries into your interstitial. And remember, left-sided heart failure is more pulmonary, so pulmonary congestion from impaired left ventricular function. The left ventricle is unable to pump blood into the systemic circulation and the aorta effectively. So the pulmonary pressure, pulmonary venous blood volume increases, which will force the fluid from your capillaries in your lungs into your tissues and your alveoli, which is why you have this edema. And then you have impaired gas exchange. Please remember that even though a patient has left-sided heart failure, they can still also have right-sided heart failure and vice versa. You don't have to have one or the other. You could have both. When it's a more right-sided, you're going to have systemic issues such as JVD, dependent edema in your legs, your ankles, your sacrum, your scrotum. It's going to be pitting. I've seen some poor scrotums the size of basketballs. I feel really sorry for those people. Abdominal distension, ascites, fatigue, weakness, hepatomegalia, which is enlarged liver, tenderness, weight gain. When you have right-sided heart failure, you're going to have nocturnal polyuria. But with left-sided heart failure, you're going to have oliguria. Left-sided, you're going to have dyspnea, orthopnea, nocturnal dyspnea, which is shortness of breath at night. You're going to have an S3, pulmonary congestion. You might start to have organ failure issues, such as the oliguria. This is because of the decreased perfusion to organs. And you could have frothy sputum. I know ATI has that listed as an expected side effect. However, I would not expect frothy sputum. That to me is a warning sign that pulmonary edema is starting to occur. So if you see frothy sputum, you should have red lights going off. Some lab tests that you're going to do is a natriuretic, ultrasound, echo. If it's acute, you're going to hemodynamically monitor them, but we're not dealing with acute. We're only dealing with chronic. They could have a TEE ordered, which is basically an ultrasound down the throat to look at the backside of the heart. You're going to need to be NPO for this because they're going to put a scope down your throat. They're going to sedate you. Chest x-ray, EKG. The chest x-ray will show us if you have cardiomegalia. It'll also show us if there's any pulmonary edema going on. An EKG is like a window into the heart, like I said earlier. And then some labs, troponins, to see if there is any specific heart damage, because heart damage can lead to heart failure. Electrolytes, specifically your potassium, your sodium. You might want to look at the sugar. And then ABGs to see if there's an acid-base disorder going on. Predominantly with heart failure, we're more worried about the pulmonary, so you're probably going to see a respiratory disorder. The nursing care of heart failure, daily weights. Make sure that they are weighed the same time every single day in the same clothing. Eyes and nose. You give them oxygen if it's prescribed. Remember, oxygen is a medicine, so you should have an order for it. So if you have to put them on oxygen, get an order. Make sure they're in high Fowlers to maximize ventilation. And remember, we're going to do least to most, so we're going to put them in high Fowlers first before we give them oxygen if they're in distress. Again, we're going to monitor vital signs and hemodynamics. ABGs, electrolytes, the pulse ox, the chest x-ray findings. We want to assess for med toxicity, specifically digoxin. What are our symptoms of digoxin toxicity? Well, fatigue, anorexia, nausea, visual halos, visual disturbances. If they're having an acute exacerbation, we want them on bed rest until they're more stable to move around. If it's chronic, they don't need to be on bed rest. But you can have an acute exacerbation of a chronic heart failure. Encourage energy conservation. So let's huddle our activities so we're not bothering them all the time. Maintain dietary restrictions. What kind of diet? Well, we want a low salt, limit our fluid diet, and, emotional support as needed. Make sure you have a list of herbal supplements, because guess what? Some herbal supplements can affect cardiac meds. If they are on herbal supplements, you need to educate them on which ones can affect cardiac meds. So our diuretics, they are going to decrease our preload. We have loop, thiazide, and potassium sparing. The big thing with diuretics that we want to remember is our electrolytes, potassium. Loop diuretics, thiazide diuretics can make us hypokalemic. Potassium-sparing diuretics can make us hyperkalemic. If we're giving the medicine IV, we want to make sure that it's not faster than 20 milligrams per minute. And ototoxicity, like ear toxicity, can happen with too rapid of administration. We want to educate on position changes. Be slow. High potassium foods. What are our high potassium foods? Fish, citrus fruits, potatoes, avocados, those things. Our afterload reducing agents, so our ACE inhibitors, our ARBs, our calcium channel blockers, our phosphodiesterase inhibitors. Contraindications or consideration for these is they're contraindicated if you have some kind of renal issue. We want to always monitor for hypotension. All of these can lower our blood pressure. Angioedema, specifically for ACE inhibitors and ARBs. Swelling of the throat. And then we want to monitor for increased levels of potassium with our ACE1s and our ARBs. Client education, we want to inform them that they can develop a dry cough. If they do develop a dry cough, they need to tell their provider, because the same pathway that ignites the dry cough is the same pathway that causes the angioedema. If they develop the dry cough and the provider takes them off of an ACE inhibitor, they're going to put them on an ARB. Then we also want to tell them to, hey, notify us if you have swelling of your face or extremities. And again, orthostatic hypotension can occur because they lower the blood pressure. So digoxin, dopamine, dobutamine, all these things are going to increase our contractility and improve our cardiac output. Digoxin specifically, we're going to monitor the apical pulse for 60 seconds, not 60 minutes. I apologize for that. And you're going to teach the patient to take their pulse before taking digoxin. You want them to take digoxin at the same time every single day. You don't want them to take antacids at the same time. The antacids need to be taken 2 hours before or 2 hours after, no closer, because antacids can interfere with the metabolism of the medicine. You want to have digoxin and potassium levels checked regularly, because digoxin or hypokalemia can potentiate digoxin toxicity. And I talked about digoxin toxicity in the other video, so if you need a refresher on what that is, please refer to the other angina video that talks about digoxin toxicity. So beta blockers are going to block the catecholamines, beta cells, that increase our heart rate, so they're going to decrease our heart rate. The considerations is you need to monitor the pulse right before you give it. You need to monitor the blood pressure. Beta blockers can cause some fatigue, so you need to let the patient know that that might be expected. When they go home, they need to be able to take their heart rate and to monitor their blood pressure. This is for acute, the human B natriuretic peptide, necseritide, it's for an acute exacerbation and they're going to be in the ICU. The only way you can give it is IV. Vasodilators, I'm pretty sure I talked extensively about them in the angina video about nitroglycerin. Isosorbide is another vasodilator. Please remember that it's very important to teach patients to weigh themselves at the same time every day with the same type of clothing on, the same scale. If they have a change of 2 to 3 pounds a day or 5 pounds in a week, they need to let their primary care provider know or adjust their diuretic as they've been instructed previously. Our interprofessional care, we have cardiology and pulmonary services. We have cardiac rehab and we have rehabilitation as well as nutrition. So a big complication of heart failure is the pulmonary edema. I'm not really going to talk too much about pulmonary edema at this time. We're going to talk about it when we do pulmonary. But there is a cardiogenic pulmonary edema, which is what this is. Again, if you have frothy blood-tinged sputum, that is a sign of pulmonary edema. Oops. And then we talked about cardiac arrest and what to do, and you saw the video. So if you want to watch the ZDogg video again, go right ahead. So, I hope this overview helped you. If you have any questions, please do not hesitate to ask.